all the cranial nerves with various functions are actually distributed in the base of the brain, which involves mainly midbrain, pons, as well as medulla. Now, here on the left side is a cranial nerve. On the right side, I have shown where it comes out. It's very interesting to know that each of the cranial nerves has got some sort of a fissure or some sort of a foramen where it comes out. And it is very, very important that certain foramen or certain fissures actually are there where 2 or 3 cranial nerves traverse. So starting from the cranial nerve 1, which actually comes through cribriform plate, then optic nerve obviously comes through optic canal. Then from the superior orbital fissure, there are certain syndromes which we call superior orbital fissure syndrome. It involves third cranial nerve, the fourth cranial nerve, oculomotor, trochlear, the first and second divisions of the trigeminal nerve. Foramen rotundum carries second division, ovale carries third division, that is maxillary and mandibular, and meningeal branch of the mandibular sometimes also passes through foramen spinosum. And internal acoustic matters, we know the facial as well as vestibulocochlear nerve traverse. These are all very, very important for localization. And of course, jugular foramen carries 9th, 10th, and 11th. And hypoglossal canal, which is close to the again that same base of the skull, carries hypoglossal nerve. So it is all very, very important to understand before going into the actual examination of cranial nerves. This is again another view, which is the base of the brain. We can see the various nuclei where all it is there. The oculomotor nucleus, which is close to the Edingle-Westphal nucleus, which is part of the pupillary reflex. Then trochlear nucleus. Then the fifth cranial nerve. We all know there are various nuclei in the form of motor nucleus, sensory nucleus, and spinal nucleus. Then there are other nuclei which are shown in all throughout the brainstem. All these nuclei are distributed. Now, we'll come to each of the cranial nerves. The olfactory nerve is unique in itself that it is in close relation to certain structures in the brain. For example, it is in close relation to amygdala. Then it is close relation to the cribriform plate of the ethmoid where it is actually closely attached. And of course, the frontal lobe is also very close. So these are very, very important because certain disorders, for example, olfactory groove meningioma can also present with frontal lobe related symptoms. So these are all very, very important. The olfactory nerve, apart from the nasal cavity, the olfactory pathway consists of various cells. We'll not go into the details of this. Why I wanted to show was olfactory nerve, even though it's a very small extension, it is also consists of similar type of distribution of action potentials as well as the propagation of the impulses. Olfactory nerve examination is simple. What is important to remember for the students to remember here is the eyes should be closed. And the standard substances which are used, which are commonly available, I have only shown commonly available substances which can be used on bedside. Coffee, which most of us can smell, the smell of a soap, lime, or sometimes toothpaste. Some books give eucalyptus and all. But what is important to remember is it should not be a pungent odor or pungent sort of a smell should not be used because it is supposed to stimulate the trigeminal nerve also along with olfactory nerve. So eyes has to be closed, and after ensuring that nasal passages are clear, each nostril has to be tested separately. Like what is shown here, the eyes should be closed and one nostril should be closed, and ask the patient to take 2 normal sniffs, not a deep sniff because it stimulates the trigeminal nerve. Then 2 questions should be asked. One is if he can smell anything. If answer is yes, then it should be asked what is the type of this. What is the smell? Now there are certain tricks here. Some individuals are there who actually are very good in the recognition of smell. Generally, there are some people whose olfactory receptors are possibly more sensitive, and some people possibly are a bit slow in recognition. So time is not the factor here. And there are some people who are able to detect smell. Different types of smell also they can differentiate, but 1 or 2 of them they may not be able to identify. That is actually perceived to be normal. And before branding any abnormality in the olfactory nerve examination, one should always rule out the nasal causes or local causes, because rhinitis, rhinosinusitis, atrophic rhinitis are some of the common causes. Polyps are some of the common causes of anosmia or parosmia. Now coming to optic nerve. Optic nerve examination includes various subheads. It starts with visual acuity, which itself has got two parts. One is distant visual acuity, near visual acuity, and then evaluation for color vision, which is again a macular function, field of vision, which is a peripheral function, and it is done on bedside with finger confrontation test. Then pupillary reaction. One should remember pupillary reaction, the afferent is the second nerve, efferent is the third nerve. So I am describing pupillary reaction here. I will not be describing in third nerve. The pupillary reaction should be checked is direct as well as consensual, and finally fundoscopy. So this is just a little bit of revision of physiology and anatomy. We all know that the object which is shown has got two fields. The object itself has got a nasal field and a temporal field. And once it comes to the retina, that crosses on the opposite side. But eventually what happens, the nasal item on the nasal field will actually be going in the same side because of the double crossing. And what happens is once from the retina, it goes along the optic nerve, and in the optic chiasma, the nasal fibers cross over, whereas temporal fibers will remain on the same side. So eventually you have optic tract, and then subsequently after the lateral geniculate body is optic radiation till the primary visual cortex. So this is what is the basic anatomy which we all know. And eventually what happens, the image of the whatever those two images are actually once in the mind eye, it is reversed. So this is one sagittal section which is showing that through the optic nerve, through the optic chiasma, optic tract, and optic radiation, and finally to the primary visual cortex. So how to check visual acuity and color vision? What is standard, what is followed in practice, most so by ophthalmologists and optometrists, is the 6 meter or 20 feet distance, wherein we use Snellen's chart. Now, this is a Snellen's chart wherein distances are given in both 6 meters as well as 20 feet, and the letters are larger, and as the person is able to read the lowest one, that means his vision is better. And we all know 6 by 6 is supposed to be the normal vision, and 6 by 60 is supposed to be blind. But what is important here to know is whenever the vision is checked, each eye should be checked separately. And what is very, very important here is you ask the patient to cover the eye. Don't ask the patient to close the eye, because once the person closes one eye, the other eye also might partially be closed. Because of the partial closure, people who have got astigmatism or even myopia may have some blurring of vision which will interfere with exact interpretation. So this is a very important thing we should know. Now, the lower down, which is there, is a Jigar's chart. The Jigar chart is kept at a distance of 30 centimeter in front of the patient, and the patient is asked to read, and the normal value which is given is N5, which is normal value. But another thing which is important is most of the clinicians carry something called Rosenbaum chart. The Rosenbaum chart has got both distant as well as near vision, which is a sentence is there, and it got a pupillometer also. So generally the patient is given, and it is tested at a distance of 40 centimeters, which is generally used in clinical practice. But for all practical purposes, this is used, but ideally one should use Snellen's as well as Jigar chart. For color vision, which is again a function of the macula, what is used is Ishihara's isochromatic plates, and which has got various numbers in various colors, and the individual should be able to properly read it. And usually for certain normal vision means it is color perception 4 is considered to be normal, even though for armed forces and police recruitment and all, color perception 2 is considered better. Coming to the field of vision, we all know that field of vision, ideal way of checking field of vision is a perimetry, which is done by an ophthalmological center. But in bedside, we do field of vision. In the field of vision, the individual is seated in the same height, in the same height stool, which is at the same level at a distance of 1 meter from the clinician. And initially, both eyes are tested. And what is important here to instruct is the individual from his left eye will look into the center of the right eye of the examiner and vice versa. So that virtually means, to simplify things, he has to look into the eyes of the examiner and not look sideways. He has to just focus there. And the examiner, what he will do is, he will start with and he is actually checking the confrontation of the finger confrontation of his vision with the patient's vision, and it is assumed that the examiner has a normal peripheral vision. That is the assumption. Now the examiner starts with some moving finger, and it starts from the there are two options. Either he can start from the center and then he can move peripherally, and when the individual is unable to see the finger, or he can start from outwards and start asking him when he can see the finger. Preferably moving finger has got a better ability to be recognized than a static finger. So that again, both sides should be done first, and subsequent to that, each eye is closed. Like for the examining the individual's left eye here, the examiner is seeing through his right eye, and the examiner, if he has got any glasses for correction, he should always wear the glasses, and as is shown in this diagram, it has to be checked correctly. The 1 meter is the distance, and whenever there is any problem like any hemianopia on any side, it is perceived in that appropriately. Now, as I told you, I'll be describing the pupillary reaction and accommodation reflex here only. What is important is, there is something called direct reflex, there is something called consensual reflex. Light is shown from the side of the eye. It is very important. There are two important aspects before doing the pupillary reflex. The first important aspect is, as much as possible, the individual should be in a dark room, because dark room actually dilates a pupil, and then when you throw the light, it is easier to look for the pupillary constriction. It should be ideally done in a dark room, or it should not be done at least in a room where a lot of brightness or light is there. And the light is shown from the side of the eye. It should not be directly shown into the eye for two reasons. Again, because directly if you show, then you may not be able to see the actual reaction, and secondly, it will be very inconvenient and difficult for the patient to perceive that immediate light. And what generally happens is, once the light is shown, there is immediate constriction of the pupil immediately, followed by a little bit of dilatation, and then it will come to the mid position. This is a normal reaction, and same thing is actually happens on the other pupil also. So here, whenever we check for the light reflex, what happens on your left side is the light reflex, on the right is accommodation reflex. I'll be coming to that subsequently. In the light reflex, whenever you show a light, here it is actually shown from the front, it should be preferably from the side. The other eye, the examiner should observe, and he should see whether it is constricting or whether it is dilating. Coming to the accommodation reflex, the individual is asked to look at a distance. When the individual is asked to look at a distance, then suddenly he is asked to look at the finger, which is approximately around 20 to 22 centimeters in front of the eye. Once he sees, there are three things which occur. The three things which occur is, one of them will be pupillary constriction, another will be the thickening of the lens because of the action of the ciliaris muscle, so that zonule is relaxed and the lens thickens, and the third will be the medial deviation of both eyes, which causes convergence with action of both medial recti. Well, we're coming to the pathway now. Sorry. So the pupillary reaction, the light reflex, which is pupillary reaction, afferent is through optic nerve, then optic chiasma, and from the optic tract, it goes to both the Edinger-Westphal nucleus. This is very important. This is the reason why there is consensual reflex, light reflex. And from there, the efferents come, and through the pretectal nucleus, through the pretectal as well as Edinger-Westphal nucleus, subsequently comes, and through the ciliary ganglion, the postganglionic fibers go and give supply to sphincter pupillae through short posterior ciliary nerves. Whereas in the accommodation reflex, what happens is, from the accommodation reflex, the pathways goes to, again, from optic nerve, optic tract, optic radiation, and from there fibers go into the frontal eye field, which I am showing here, the frontal eye field, and from the frontal eye field, again the nerves are supplied again through the Edinger-Westphal nucleus and through the short ciliary nerves, again constricted pupillae, as well as fibers to the medial rectus fibers, and as well as to the ciliaris muscle, which relaxes the zonulis so that lens is thicker. This is the pathway for accommodation reflex. So again, before coming to the next slide, I would like to again highlight here. I would like to highlight here again that it is very, very important to shine the light from the side and ask the patient to look far ahead whenever you test the pupillary reaction, because if the individual is looking nearer, there may be some constriction because of accommodation reflex activation. Here again in this diagram, which I have already explained, the consensual reflex is explained because there is bilateral supply to both the Edinger-Westphal nucleus. So coming to the fundoscopy, which is a very, very important aspect, please, one should always remember the second cranial nerve is a direct continuation of the brain substance itself, and optic nerve is surrounded by the meninges. So any raised CSF pressure, any raised intracranial pressure is manifested by papilledema. So it is one of the simple bedside tests which actually can diagnose life-threatening conditions, and quick action can be taken in sorting out the problem. So this is a fundoscope. We should all know that there are two types of fundoscopy. Whatever we actually do is a direct fundoscopy, which we do at bedside. There is something called indirect fundoscopy, which ophthalmologists do, which is possibly a bit more complicated, but for all practical purposes, whatever we do is a direct fundoscopy. These are the parts of the fundoscope. You have a brow rest on the examiner's side and a viewing window, and then there is a diopter power display. And people like me who have got a spectacles, we have to adjust the diopter power display as per our requirements. If somebody is myopic, it has to be whatever power is there. If somebody has got -1 power, the diopter has to be adjusted to -1 so that you can see it clearly. And then this is a light on off switch. Whereas on the patient side, you have an aperture dial wherein you can actually, the aperture of light, depending on what strength of the light is there, that can be used. So here what is important is, once you start doing fundoscopy, it actually comes with practice. Once light is shown, and again very, very important, I'm dealing it in the pearls part also. What is important is some clinicians, especially ophthalmologists, they are more comfortable after dilating the pupil to see the fundus. But ideally, it is not actually comfortable for the patient subsequently for 3 to 4 hours. And whenever you are suspecting any raised intracranial pressure, any coning, then you may miss the actual uncal herniation, because already pupil is dilated because of mydriatic drops. So as clinicians, as neurologists, we generally try and do fundoscopy or do fundoscopy in an undilated pupil, normal pupil. So preferably it should be done in a dark room so that maximal dilatation of pupil will occur normally, naturally. And you go through an angle and you view the patient's, through the patient's pupils, you try and view the fundus, and then with this angle you go as near to the patient as possible, adjusting the diopter dial of the equipment. You can see here, this is a normal fundus. The normal fundus, actually there is an optic cup which is in the center, and the macula is the peripheral region, and these are the veins. Veins are a bit thinner, arteries are a bit thicker, and you can see arterial pulsations. Arteries actually move, veins generally move very, very less. So there are certain normal variants which is not required for non-ophthalmologists, but what is important for us to know is the central macula is there, central optic cup is there, which is also called disc, and then veins and arteries. Whenever there is papilledema, what happens is the cup, the appearance of cup is blurred. So the optic disc or cup is blurred, and there may be some sort of either there is loss of arterial and venous pulsations, which is by practice one can see. So here, what can be seen here is on the left side, the diagram A is a normal fundus. What is shown in blue is an artery actually here, and what is shown in yellow is a vein here. We can see the artery here, we can see the vein here. Just below that is papilledema. You can make out here, see, this is a normal disc, and you can see here the normal disc, the differentiation between the fundus and the disc is gone. There you cannot make a differentiation with the margin. The margin is blurred. And we can also see that there is a lot of tortuosity of the vessels. Whereas on the C diagram, which is actually optic atrophy, in the optic atrophy, what is seen is you can see there is a lot of paleness in the entire disc, and the vessels are actually normal. And the lowermost, which is D, is a glaucoma. In the glaucoma, the actual size of the cup is huge. The cup size is enlarged. So it is possibly because of raised intraocular pressure. So what is important for us to remember is, once we see, whenever there is a blurring of the margin of the disc or cup, that is an early sign. That's a sign of the papilledema. This is very, very important because this is one bedside test which can catch, which can possibly alert a clinician to possibly go for a quicker investigation so that life-threatening conditions can be tackled. So this is a simple type of a flow chart which is there. Whenever you see a fundus, what is the fundus color? Whenever the fundus is pink, one has to look at the disc margins. Nasal margins sometimes can be blurred. We have to look at the temporal margins. So if it is clear, then look at the optic cup. If the optic cup is normal, then it is a normal fundus. Whenever there is a blurring of the cup, which I had shown like that, possibly it is optic nerve head swelling. Optic nerve head swelling is nothing but papilledema. Whereas whenever there is a white or paleness in the fundus, whenever you see, again one has to look at the optic cup. Whenever the optic cup is normal, it is optic atrophy, which I had shown in the third diagram. And whenever optic cup is deep and it is huge, then it is possibly glaucoma. This is how a simple way of trying to look at fundus. Now, once you do the vision testing by actual perimetry and then confirmed by perimetry, these are certain visual abnormalities one generally sees. And whenever there is any abnormality in any of the which part branch of one side, nasal or temporal side of the visual pathway, there may be possibility of a scotoma, central scotoma, which is a central part which is unable to see. And whenever there is any problem at the optic nerve on one side, there is complete blindness on that side, which involves the entire nasal as well as temporal half, which is shown here in the diagram 2. Whenever there is involvement of the central part of the optic chiasma, which is actually, you can say, the exact central aspect of the optic chiasma, you can see here that the nasal fibers on the left side and the nasal fibers on the right side are there. So what happens here is bitemporal hemianopia. This is a common cause in pituitary gland related problems, which is usually macroadenoma and sometimes microadenoma also. This is bitemporal hemianopia. This is a very important aspect. Whenever such a situation occurs wherein only from the periphery there is a compression, rarely there may be binasal, but usually it is on one side. So it is nasal hemianopia, uninasal or binasal hemianopia if it occurs compression from both sides. Whenever there is a problem in the optic tract, whenever optic tract is injured or affected, what happens is homonymous hemianopia. That means the same side, because this optic tract carries the, if you see the blue temporal part of the optic nerve on the left, as well as temporal nasal part on the right, which is actually homonymous hemianopia, which is both sides same type of vision is affected. Whenever there is any, there is some sort of a, there is a genu type of a structure which is just before the optic radiation. Whenever there is a problem here, there will be again some sort of a superior quadrantanopia. This is common whenever there is infarct, especially in the parietal region. So this is, it causes superior quadrantanopia. The superior quadrant, you can see here, number 6, it is affected. Sorry. Whenever there is involvement of optic radiation possibly causes, it is not very congruous, it may be incongruous, some sort of a quadrantanopia. It may be large on one side, it may be small on the other side. And whenever there is involvement of the optic radiation close to the visual cortex, again there may be, rarely there may be homonymous hemianopia. But what is important to note here is whenever there is involvement in the occipital lobe, there may be blindness homonymously, but the macular part is spared. So this is a type of possibly the abnormalities which are classically described, but sometimes there may be some patchy visual loss which may not exactly correlate with this, but it is very important for us to know these aspects. So this again, I have possibly this is a bit more complicated. I've explained with the diagram. So it is the same type of a diagram which is explaining the same. So before going to the next cranial nerve, one should always remember that whenever we test visual acuity, one should remember that the patient is asked to cover the eye with a hand and not close the eye. The reason I have already told. And whenever you are testing the finger confrontation test, poor fixation is a very important impediment, so that may interfere with the confrontation test. The individual has to focus on the examiner's eye. And very important, for at least for clinicians, what we follow is fundoscopy should be tried and done in as much as possible in an undilated pupil in a dark environment, and you will get definitely important information, and you will unnecessarily dilatation of pupil is not recommended. Now coming to the important, this is possibly one of the most important cranial nerves because it has got so many tests to be done. The third, fourth, sixth, it's together called oculomotor nerve complex. So there are various tests which are done looking for ptosis, partial ptosis, pupillary reaction, extraocular movements, looking for movements like Saccard's pursuits and nystagmus, and evaluation of diplopia. It is very important. Now we all know that the third, fourth, sixth cranial nerve has got very important anatomical considerations because they also pass through cavernous sinus, they pass through superior orbital fissure, and then they are close to posterior cerebral artery, superior cerebellar artery. I'll be coming to the importance of each of these, why it is important subsequently. What is important here to learn is there are two things which one should always remember. That is medial longitudinal fasciculus. Medial longitudinal fasciculus is it's a type of a midline structure which actually interconnects third, fourth, sixth nerve, and which is involved in the control of eye muscles. And in this diagram I have not shown, there is something called PPRF, pontine paramedian reticular formation, which is also an important structure in eye movements. Now we should always remember that Saccard, which is a sudden jerky movement to fix to turn at some or to look at some object, which is a command which is controlled by the contralateral frontal lobe, whereas pursuit is a movement which is following movement, which is ipsilateral occipital lobe. So this is very important to know. And then there are certain vestibular reflexes which are vestibular and positional receptors which are in neck, ear, and vestibular apparatus inside the cochlea. So these, along with the brainstem as well as the medial longitudinal fasciculus, control the eye movements. Now, pupillary reaction I've already described, but I would like to describe one thing here, something called relative afferent pupillary defect, what is called RAPD. What happens here is whenever light is shown on the one side, the pupil constricts. But then once light is shown the other eye, the pupil, instead of constricting, it is dilating. That is because it is still having the effect of the consensorial reflex. So that means the consensorial reflex is stronger than on the direct reflex, or direct reflex is weaker than the consensorial reflex. So that is, so it is also called Argyll-Robertson pupil, and there is a mnemonic which all of us remember from MBBS days, ARP, accommodation reflex present, pupillary reflex absent. The commonest cause for this was earlier used to be neurosyphilis. Now these days retroviral infections are also found to be a cause for this. So whenever you have any pupillary abnormality, there is a way to approach. Whenever pupil is large, that means mydriasis. When it reacts to light, normally, then possibly it is some sort of a physiological anisocoria. Whenever the pupil is large, doesn't react, possibly, and normal accommodation, it may be, as I was already mentioning, afferent pupillary defect will be called RAPD. Whenever there is accommodation is slow, there is a condition called, which is a congenital condition, Holmes Addy pupil. Whenever there is no accommodation also, possibly, probably, it is, whenever there is a ptosis, it is probably third nerve involvement. Third nerve also supplies levator palpebral superioris, which will cause ptosis. And whenever there is no ptosis, then possibly it is mydriatic drugs. Whenever pupil is small, if it still reacts to light, it maybe possibly senile meiosis. Whenever there is, along with that, features of Horner syndrome, other syndromes like anhidrosis and ophthalmos and all, that is possibly Horner's, and it does not react to light. And whenever there is normal accommodation, it may be one of those irregular Urgell-Robertson pupil, which is recently you have tested. And whenever there is no accommodation, there are some drugs which can cause meiosis also. So it is a way to approach pupillary abnormality. Coming to the extraocular movements, the extraocular muscles are supplied by different nerves other than superior oblique, which is supplied by fourth cranial nerve, and lateral rectus, which is supplied by sixth cranial nerve. All other extraocular muscles are supplied by third cranial nerve. And we should also remember levator palpebrae superioris is also supplied by third cranial, which is an important factor in ptosis, which is drooping of the eyelid. So the muscles, whenever there is, these are the actions of the muscle. Superior rectus, inferior oblique actually elevates. Superior rectus does so with abduction, and inferior oblique does so in adduction. And similarly, superior oblique and inferior rectus does the depression at their various stages. So what is important is pure elevators are superior recti and inferior recti, whereas the pure inverters or depressors are superior oblique and pure elevators are inferior oblique. So superior rectus, whenever you are looking laterally and upward, it acts best. Inferior rectus is laterally and downward. Lateral rectus, of course, it acts on the horizontal axis. It looks laterally. Medial rectus looking medially. Inferior oblique is actually looking upwards whenever the looking medially, and superior oblique is opposite of that. So this is a very important concept which we must know before understanding other things. So that is why whenever somebody looks in the primary position, all the extraocular muscles are actually acting. Whenever a person looks up and right superior rectus, left inferior oblique is acting. Similarly, I'll not go into each of the details. So it is simple to understand once you know the mode of action of each muscle. Before coming into the next test, what is important for us to know is whenever there is any third cranial nerve involvement, we should always remember, I'll be coming to that. Whenever there is sixth cranial nerve palsy, whenever you are, which is here in this patient is left sixth cranial nerve palsy, you ask him to look laterally towards the left. He is unable to do so from it because left lateral rectus is weak. You can make out here it is unable to look laterally from the left eye. Similarly, whenever there is left-sided third nerve palsy, the individual is unable to look medially. Because of that, there is unopposed action of the unopposed action of this muscle, lateral rectus. It is deviated laterally, and there is possibly involvement of the levator palpebrae superioris. He has got ptosis also. And in left fourth cranial nerve palsy, you can see here he is asked to look on the right side. He is unable to see, and because of the involvement of the left-sided superior oblique involvement, the eye is in the central position. Now, there are certain conditions, certain times when pupil is spared and pupil are involved. So what is important to remember, simply remember, is whenever there is any compression, which is the cause, so the pupillary fibers are peripherally located in the arrangement, and whenever there is compression from periphery, pupillary fibers are affected. So aneurysm or compression or vascular compression will cause early pupillary dilatation. Whenever there is ischemic problem, whenever there is something which is happening from within, like diabetes and all, whenever it occurs, pupil may be spared. So whenever there is somebody has got double vision, diplopia, due to whatever reason, how to approach? You have to ask him whether it is binocular or monocular. Usually one should remember that binocular diplopia almost always is neurological. Monocular diplopia, unless proven otherwise, is ophthalmological. Whether it is horizontal or vertical, horizontal diplopia is usually due to medial rectus or lateral rectus palsy. Vertical is usually due to superior rectus, inferior rectus, and oblique can be due to inferior oblique, superior oblique muscles. And whether it is continuous or fatigable, we know continuous diplopia is possibly due to something which is possibly not due to neuromuscular problem, whereas fatigable or diurnal variation is due to neuromuscular junction involvement. And whenever somebody has got diplopia, there is a head tilt which the person tries to compensate for the diplopia he is having, which is always evident when you examine the patient. I'll not be going into this, which I've already explained. So whenever you test the third cranial nerve, another important aspect one should know is saccades and pursuits. Now, saccades can be checked by having two targets, one on either side of the face, and asking him to suddenly look at one from another and change the gaze. That is the saccade, which can be done both for horizontal as well as vertical. For pursuit, when you do, you actually ask him to follow your finger and see in all the directions. So this is the saccade and pursuit. Now, like I already mentioned, saccade is the contralateral front light field, and pursuit is by parieto-occipital cortex of the same side. Coming to the nystagmus, what is very important here in nystagmus one should understand is whenever you check for nystagmus, you should never check in the extremes of gaze, because physiologically also there may be some nystagmus which is gaze evoked nystagmus which occurs at the extremes. One should not cross the 30-degree, more than 30-degree, either in horizontal or vertical. So in horizontal nystagmus, the fast phase moves horizontally. In the vertical nystagmus, fast phase moves vertically. And in rotatory nystagmus, there is some sort of a rotatory kind of a movement. So whenever we talk of nystagmus, one should also know the examination for optokinetic nystagmus. Usually we get those drums, these striped drums, and you rotate that drum and the individual is asked to look at them. You can see normally optokinetic nystagmus, which is present in normal individuals. So this is the evaluation of nystagmus. I think because of lack of time, I'll be skipping this because lot other cranial nerves are also left. So in the evaluation of third, fourth, sixth cranial nerve, one should again very important is ensure that there is a dark background, which is very important for reasons I've already told. And patient has to look far ahead because otherwise accommodation reflex becomes active. And light has to be shown from side, it should not be directly. And rules of diplopia is very important for anybody to understand the concept of that. Now coming to the trigeminal nerve. Trigeminal nerve examination includes sensory, motor, corneal and conjunctival reflex and jaw jerk. Now trigeminal nerve has got various nuclei. One is of course the principal sensory nucleus, which is also called main sensory nucleus. Then there is a spinal nucleus which actually goes down up till the cervical spine also. Then there is mesencephalic nucleus and the motor nucleus. So it has got various actions accordingly and each of them is tested separately. And the trigeminal nerve, the sensory nuclei includes mesencephalic, main sensory as well as spinal nucleus, whereas motor is only single. Now facial sensation is very important for one to remember. So one should remember the first division or ophthalmic actually starts from the vertex and it includes most of the part of the eye except the outer canthus and also the tip of the nose, which is very important to know. Whereas the second division starts from the outer canthus of the eye and most of them including philtrum is possibly in the mid of the cheek. And the mandibular division supplies tragus also. These are the important areas one should know. And this C2, C3, C4 are actually the dermatomal supply of the cervical dermatomes. And one should always remember there is no supply, cutaneous supply for C1. It is supposed to supply meninges. Sorry. Now coming to the motor examination, three muscles are tested. In them, most important is pterygoid muscle. Pterygoid muscle, lateral pterygoid, medial pterygoid, jaw movements are tested. The patient is asked to open the jaw, open the mouth. The patient is asked to move the jaw on both sides. Now, what is important here is whenever there is any paralysis of any one side of the pterygoid, it is pushed because of the normal action of the pterygoid on the from the normal side to the affected side. So what is important here to note is whenever there is any paralysis of pterygoid muscle, because of normal functioning pterygoid on one side, it is pushed to the abnormal side. And how to test masseter? The individual is asked to clench his teeth and a spatula is kept beneath the teeth and you see on both sides from the molar teeth the impression. So you can see the strength of the masseter. Coming to the corneal reflex. Corneal reflex again, what is important to know here is from the periphery again, it should not be causing him Menan's reflex to him, it should be from the side. And the cotton wisp should be wet with a sterile cotton which should be wet and one should touch the periphery of the cornea, which is totally in here, not in the central part. And we can see here, this is the entire cornea, this is a pupillary area, so it should be touched in the peripheral aspect, and both eyes should blink. The afferent is fifth cranial nerve, efferent is the seventh cranial nerve. Conjunctival reflex is similar in terms of pathway, but however, conjunctival reflex, you actually try and touch the bulbar conjunctiva part in the sclera. The jaw jerk is one of the tests which are supposed to be not very reliable, but it has got its own significance. The individual is asked to open the mouth slightly, and then from above downwards direction, the patellar hammer is hit on the finger, and the normal movement is there will be slight closure of the mouth, which is a normal movement, which may be absent in normal individuals also, but if it is exaggerated, it has got a very important significance. So what is important here is knowing the trigeminal sensory distribution is very, very important, like the involvement of the nose, which part is supplying the tragus is very, very important. And it is clinically, when we test, it is sometimes very difficult to test the sensation in some patients because of the possibly sensitivity of various sensations on the face, as well as some for reasons which is of course unique to the patient. Patient may not be comfortable to get tested on the face, especially pain sensation. And jaw jerk, even though it is not a very reliable test always, but whenever there is a brisk jaw jerk, it is a very strong, gives strong information that there is a brisk human sign. Coming to the facial nerve, the facial nerve is tested by muscles of facial expression, then in the sensory taste in the anterior two-thirds of the tongue, then secretory functions and reflexes. The facial motor evaluation, various muscles are tested. This is frontalis, this is orbicularis oculi, this is buccinator, and then this is the orbicularis, this is angularis oris, and this is buccinator. These are the muscles which are tested. Individual is asked to give these positions, and you have to look for the symmetry. Like in the frontalis here, you can see the symmetry, it is symmetric. And in the orbicularis oculi, please remember you should try and open the eyes from above, not from below, because the orbicularis oculi, you have to test here, not the lower eyelid. And then buccinator, you ask to make him to keep the air there and try to push it. And then your angularis oris, which is for the oral cavity, ask him to clench his teeth. There are certain other tests wherein you ask him to protrude the chin so that masseter is also seen, and then ask him to tighten his neck so that his platysma is also seen. These are the various muscles which can be kept into action. Each of these muscles may not be required to be tested in every individual patient. Then coming to the secretory functions, the tears is also supplied by it is one of the functions of the facial nerve. Now what is important here is objectively it is tested by using a filter paper with a marking on that, and the individual, both the sides it has to be kept, which is between the lateral and middle 1/3 of the lower eyelid, and it is kept for 5 minutes. In 5 minutes, if the length is less than 5 millimeter of the wetness, it is suspected to be possibly suggestive of possibly dryness, which is an indicator for Sjogren's syndrome. Now, taste examination. Here it is very, very important to know that the anterior two-thirds of the tongue is supplied by the facial nerve, taste sensation, and the posterior 1/3 is glossopharyngeal nerve, and epiglottis is motor function is by the 10th cranial nerve. The sensation just in and around the epiglottis, which is and posterior 1/3 of the tongue, is by the glossopharyngeal nerve. Now, here the patient's eyes are open. The individual will open the mouth, keep his tongue protruded. The tongue has to be initially has to gargle with a normal water, so that whatever he had food or whatever intake has been there, that has to be taken out. Then the normally sweet, salt, sour, bitter is used, and bitter is used in the end because its effects last longer. And after asking to protrude the tongue, as per the books, you are supposed to hold his tip of the tongue with a gauze, and then try and put whatever the taste object on the lateral aspect of the tongue, and ask him to perceive. You leave about say 10 to 20 seconds, and then you should have 4 cards: sweet, salt, sour, bitter, and he has to show with his finger because he is unable to speak. This is how you actually test the taste sensation. Now, in the facial nerve, it is very, very important to know why is it important to localize, because one should always remember that the upper half of the face has got bilateral UMN representation, bilateral cortical representation. So, whenever there is a UMN type of facial palsy, upper half of the face is spared. Like what you can see here, upper half of the face is normal. Here you can see, whereas whenever there is an element type of facial palsy, which is actually this, whenever there is a lesion is here, complete face is involved. Whenever there is a kind of a central lesion, like the problem is here, because of bilateral cortical representation, even though these fibers are cut, the individual is still receiving supply from the other side, the upper half of the face is spared. So remember, for all practical purposes, LMN facial palsy is a complete facial palsy. UMN facial palsy is a partial facial palsy. So this is what we have shown in the diagram. Whenever the face is asymmetrical, so you look for LMN versus UMN. I'll be describing it subsequently. So what is important here is LMN facial palsy. This is where I'm describing. LMN facial palsy is complete because the entire face is involved on one side. And whenever such cases occur, one should always look for opposite side pyramidal tract signs, because there is something called crossed hemiplegia or crossed pyramidal tract syndromes, wherein whenever there is midbrain lesion and whenever there is any pons lesion, there may be, or whenever there is medulla lesion. In the pons lesion, especially whenever 7th cranial nerve nucleus is involved, the nuclear that is complete facial palsy element will be there on that side. On the opposite side, pyramidal tract is involved because pyramidal tract crosses in the lower 1/3 of the medulla. Whereas UMN facial palsy, upper half of the face is spared and it is usually associated with ipsilateral pyramidal signs, classically in strokes. Coming to the 8th cranial nerve, in the 8th cranial nerve, the test which you do is Rene's test, Weber's test, absolute bone conduction test, oculocephalic reflex, and caloric test. I'll not go into the details of the vestibulocochlear nerve. Rene's and Weber's test. In the Rene's test, please remember 512 is a tuning fork which is used for testing Rene's and Weber, and 128 Hertz is used for testing vibration. So initially, the individual is shown how he should how the sound of the tuning fork. Afterwards, one is he's asked to tell whenever the vibration stops or whenever he's stopped, whenever his listening is stopped, he has to say now or yes. Then you have to keep it on the initially keep it on the tuning fork is hit with 512 tuning fork. Ask him whether he's perceiving normally. Then you hit the tuning fork, keep it on the mastoid process. He will start hearing. Then once he stops feeling that, you have to keep it next in front of the ear. He has to still feel. That means air conduction is better than bone conduction, which is a normal phenomenon. So whenever there is any problem with Rene's test, I'll be coming to the interpretation. So whenever there is any problem with conductive hearing loss, his air conduction will be less than bone conduction, or bone conduction is more than air conduction. That means he will not be able to hear after you remove it from the mastoid. Whereas in Weber's test, you keep it in the central, either in the vertex or in the middle of the forehead. And normally a person should feel that it is coming from the center. The sound is coming from the center. The vibration is coming from the center. Whereas in conductive hearing loss, whenever there is any abnormality here, he will be able to feel it normally on that side because bone conduction compensates for that. Whereas in sensory neural hearing loss, he will not be able to feel from that side. So it is lateralized to the normal ear. So this is the concept. Now this table explains, I'll try to simplify things to you. In a normal person, air is conducted more than bone. So air conduction is more than bone conduction. That is what is Rene's test. And Weber's test is perceiving it in the central part. In conductive hearing loss, that because of the problem in the middle ear cavity, it appears that air conduction is less than bone conduction actually, and bone conduction is more than air conduction. And it is in the Weber's test, it is lateralized to the affected ear because the compensation of the bone conduction. Whereas in sensory neural hearing loss, the Rene's test may appear normal, but however, whenever there is any, whenever you keep the tuning fork, it because of the abnormality on one side, it is heard on the normal side better. And in mixed hearing loss, there is a mixture of both the features. Now, Doll's eye and caloric test, please remember they are preferably, Doll's eye is done in a patient who is comatose, who is unconscious, and caloric test can be done in normal individuals. The Doll's eye, from the resting position of a person, the eyes are open. If the eyes are closed, then you have to suddenly turn to the right as well as left. In a normal person, the gaze is fixed towards wherever the individual is seeing, even if you turn the head. Whereas in the abnormal response, the eyes may be central. In the caloric test, you generally use 7 degrees below. The normal temperature is 37 degrees, 7 degree below and 7 degree above. So 30 degree, 44 degree water or saline is used, and the head should be at the level of 30 degree from the 30 degree elevation, so that the semicircular canals in the same level. And after confirming that tympanic membrane is intact, whenever you instill cold water and ask the patient to fix a gaze, the fast component of the nystagmus, which appears after a gap of about few seconds, the fast phase will be on the opposite side, which is on the opposite side of the installation of cold water. Whereas when you instill warm water, it is the fast phase of the nystagmus will be on the same side. So which is remembered traditionally as cows, cold opposite, warm same. Whereas whenever there is any brainstem abnormality or cortex is non-functional, it may be reversed or there may be no response. So here, in certain books say Rini is positive for a normal Rini is negative for an abnormal Rini. It is better to say air conduction, bone conduction comparison. And in caloric test, it is very, very important to ensure that tympanic membrane is intact. And nystagmus evaluation, as I've already mentioned, one should avoid extreme lateral gaze. Now, glossopharyngeal and vagus, these are the tests which we do. The palatal reflex, individual is asked to open the mouth and he is supposed to say loudly, ah. So you have to actually see the palatal movement, which moves upwards symmetrically from both sides. And the pharyngeal sensation is tested. Whenever you test the pharyngeal sensation, individual will perceive, he may actually have some sort of a cough or he may have some sort of a retching. And you have to use a tongue depressor and you have to touch the posterior pharyngeal wall or tonsil. And whenever you touch, there is some sort of a gag. The gag is the upward movement of the uvula symmetrically and the upward movement of this pharyngeal wall, posterior pharyngeal wall, which is a normal function. Whenever there is any abnormality of 10th cranial nerve on one side or somewhere, whenever a brainstem abnormality, what happens is whenever there is an abnormality, the normal side of the uvula, pulls whenever there is any abnormality, the uvula is actually pulled from the normal side, so it actually deviates towards the normal side. Instead of in pterygoid as well as in tongue weakness, where it is pushed to the abnormal side by the normal acting muscles, here it is pulled to the abnormal side. So that is what is the importance difference between these cranials. Now, gag reflex, which I have already shown, you are supposed to see the movement of the posterior pharyngeal wall as well as the upgoing of the uvula, and either you touch near the tonsil or posterior pharyngeal wall and you see the normal reaction. You can see here uvula is deviated on one side. So here, sometimes some patients may have hyperactive gag reflex, which is one of the signs of pseudobulbar palsy, which is pseudobulbar affect, which can be occurring in amyotrophic lateral sclerosis, large strokes. So those are the conditions and neurodegenerative syndromes wherein there may be, this is one of the early signs. And another important thing is there may be sometimes you can see myoclonus in the palate, which are one of those movement disorders which will still persist in sleep. Otherwise, most movement disorders disappear in sleep. Now, accessory nerve is, you test, it's a pure motor nerve again. Trapezius and sternocleidomastoid are tested. The sternocleidomastoid, one sternocleidomastoid turns the neck laterally towards the opposite side, wherein you can see the sternocleidomastoid here. So you have to test both sides by giving resistance to the neck, and you see the muscle is standing prominent. Both the sternocleidomastoid act together to flex the neck. So both together also need to be tested. And trapezius is tested by asking him to shrug the shoulders, and you have to compare both these sides. Now coming to the hypoglossal nerve. In the hypoglossal nerve, you have to look for tongue movements. You have to ask him to protrude the tongue. You see whether the tongue is central or whether there is a protrusion. or whether there is any deviation of the tongue. And after that, you look for any fasciculations and you do tongue palpation. So tongue power is also tested, asking him to press his cheek from inside and look at the symmetry between both the sides, the thickness of the tongue from within. You have to see. What is important here is, normally tongue is central. You can see here median raphe which is central, but whenever there is any deviation, the median raphe also turns and there is atrophy on this side. We can see the papillae which are atrophied here. So one question always arises whenever somebody has got facial palsy. The left image has got a facial palsy. You can see the deviation of the mouth because there is paralysis on this side. It appears that the nasolabial fold is also not seen here. It appears that the patient may have hypoglossal nerve palsy, but what is important is you should always see the philtrum should be in line with the median raphe. You can see here, this is actual 12th nerve palsy. The philtrum and the tip of the nose philtrum is actually not in sync with the median raphe of the tongue. So this is an important sign. And also you can try and correct the mouth, the deformity in the facial nerve. It becomes normal. Here it doesn't still become normal for tongue weakness. So tongue fasciculations are one of the important early sign for a motor system disease, especially amyotrophic lateral sclerosis. And I've already mentioned the difference between facial and hypoglossal nerve weakness. Now, before coming into the last part of my presentation, I'll be just wanting you to know, whenever you see a comatose patient, how to examine cranial nerves, which is a very important aspect. You cannot do the complete examination. You can always see pupillary reaction, both direct as well as consequential. It will give a lot of information. You can do fundoscopy, which I already mentioned. I don't want to emphasize it again. It's the most important test in a comatose patient, fundoscopy. Then the position of the eyes, neutral position, whenever there is any gaze, like we were mentioning, whenever, depending on the gaze, you can know whether which extraocular muscle is paralyzed. Definitely corneal reflex, conjunctival reflex can be attempted. Whenever there is any gross facial asymmetry, you can make out whether it is UMN or LMN type of facial palsy. Doll's eye is one of the part of the test examinations, which is a part of the protocol in the comatose individuals. You can see for that. Caloric test, if it is not always possible, but you can always attempt after seeing the tympanic membrane is not perforated. Gag reflex is not always possible unless patient is cooperative, and tracheal suction in intubated patients also gives a gross finding about the functionality of the brainstem. Now, there are certain conditions wherein multiple cranial nerves can be involved. I have just one slide on that. This I've already mentioned. The cranial nerves, through what all foramen it comes. I don't want to emphasize again. So what is important is cavernous sinus have got these structures. In the lateral wall, you have oculomotor nerve, you have trochlear nerve, you have ophthalmic and maxillary division of the fifth cranial nerve, and abducens nerve, which is actually close to the internal carotid artery, which is passing through the cavernous sinus. So you should remember that 1, 2, 3, 4, 5 nerves are very closely within or around the cavernous sinus. That is why whenever there is cavernous sinus thrombosis, these cranial nerves may be affected. Similarly, this is superior orbital fissure, this is inferior orbital fissures. You have inferior orbital fissure syndrome, you have superior orbital fissure syndrome, you have tendinous of ring, Zinn syndrome. So these are certain syndromes wherein various cranial nerves can be affected together. So what are the conditions? In the superior orbital fissure syndrome, you can actually have involvement of third, fourth, V1, V2 in variable proportions depending on the involvement. And whenever there is any problem in internal acoustic matters, especially CSOM, there can be combined 7th and 8th cranial nerve, which is very, very common. And remember here, it is LMN 7th because it is peripheral. In the jugular foramen syndromes, you have various involvement of 9th, 10th and 11th cranial nerves. In the cavernous sinus, which I have already mentioned, and skull base lesions, especially the skull base related skull base tumors or cholesteatomas and other problems, you can have involvement of 9th, 10th, 11th and even 12th also when it is close to the jugular foramen. So whenever there are cranial nerve abnormalities, whenever there is contralateral hemiplegia or tetraplegia, then possibly you think of third nerve palsy, like I already mentioned, crossed hemiplegia, maybe midbrain, 6th or 7th pons, 9th, 10th, 11th medulla. That is how you go about. Whenever there is no such hemiplegia or tetraplegia, whereas combined 5th, 7th and 8th, it is possibly CP angle, cerebellopontine angle, which I already mentioned. Whenever there is combined third, fourth, and V1, definitely you have to look for cavernous sinus. 9th, 10th, 11th, you have to look for jugular foramen or skull base syndromes. So I'm sorry, I overshot time by about 5 to 8 minutes, but I think I am finished now. If at all there are any questions, anything, I'm more than happy to try and answer them.
Thank you, Professor Srinath. It was wonderful. It was not short. I am rather amazed. How come you could give us so much information in such a short time? It's, I think, a very large subject which have been covered in a very lucid manner, very simple to understand. And